Thanks, Michael. It's a real pleasure to be here. And thanks to NCQA for doing all the hard work, for arranging this venue, for making this possible. And as well, our sponsors, whom you saw as they skipped by, without the support of the committed people who really drive a lot of this work, we wouldn't be nearly successful. So I reach out to them and give them my utmost gratitude. What I wanted to start out with is a little story. It explains a large part why quality is so meaningful to me. A story took place some years back, but it's not an easy one to forget, and I don't think you'll forget it. Jack was a young man who I ran across in my role as an oncologist. He had been a success story his whole life and made his folks really proud. He had knee pain, and his family doctor insisted it was this or that, and sports and so forth, but there was nothing apparent. But ultimately, they did an X-ray on Jack, and the X-ray looked like this. You don't have to be a radiologist to see that that's a lot of stuff in the knee that doesn't belong there. Apparently, the report wasn't delivered, wasn't read, wasn't interpreted, but there are a lot of finger pointing. That's Jack's chest X-ray when I saw him. That big football-sized thing in the right lung shouldn't be there. We did a biopsy, and that long word means widely disseminated cancer. Today, medical errors make up an enormous part of the morbidity and mortality in the United States. Quality seems like an afterthought. By some estimates, there are 200 to 400,000 Americans who die from medical errors every year. It's a tragedy, and it makes front page headlines when 8 innocent people die, and yet we're responsible for the deaths of hundreds of thousands. I think part of the reason that I'm here is, in some small way, to make a difference in the way quality is evaluated. HL7 started fire almost 7 years ago. It was an idea that emerged from a program that we call Fresh Look. What if you could rethink how interoperability was achieved without throwing out the baby with the bathwater? A challenge to many, because half of all healthcare information in the world is shared at some point with some flavor of HL7, and most of the standards that are named in regulation and legislation were created by HL7. So rather than just starting anew, we said, how can we integrate some of the experiences we have had and change the way we evaluate and develop standards? I think one of the biggest changes was that FHIR wasn't about the developers. It wasn't about the people who create the standard. It was created by and for the people that need to implement it. When you think about it, that's really a game-changing experience, because the people who need to use it, to take advantage of it, were the people at the fore of its development. We've continued over the past 7 years to integrate the existing HL7 standards. Those legacy standards work. I don't think anyone is interested in winding back the clock on the $40 billion or so we just spent to implement electronic health records and the other technology that serves the for information exchange, whether it's clinical research, patient care, population health, or the evolving areas of genetics and genomics. One of the important parts of FHIR is that it's global. Truly, every continent is embedded their footprint on the way FHIR is created and the way FHIR is implemented. I think later today and tomorrow, there'll be more specifics about this happens, but I wanted to give you an overview. It's your chance at a fresh look. FHIR, Fast Healthcare Interoperability Resources, really is fast. And the byword here is fast to implement. Some of our other standards took weeks or months to understand the specification. With the advent of FHIR, it can take days or weeks to implement a FHIR solution. It's also something rather unique to HL7, which is a maturity model which reflects upon the individual resources. So no longer do we look at the entire family of resources or the specification or even implementation guides, but each resource has a uniquely identified maturation. And the maturation is really a measure of its impact on utilization. We're here today because of incredible collaboration between NCQA and its partners, one of whom is HL7. I think it's important because it's been the byword of the things that we've tried to accomplish, how we collaborate. So we developed a FHIR foundation. Now the FHIR spec itself is developed within HL7, but the FHIR foundation is the home for the implementation community, for the people who need to use it, providing the tools, the resources, the gathering place to share the information, the experience, and provide the access to the framework that makes up the complex areas in which FHIR impacts. One of the exciting events that happened in the lifetime of FHIR occurred in October of 2014. Right here in Washington, the ONC Standards and Policy Committee had a joint meeting, and they reported out on a document called the Jason Report. It really identified what was the future of healthcare interoperability and suggested that open APIs and the FHIR model would solve many of the problems that we face. That evening in a Greek restaurant here in DC, some of the leading proponents of FHIR and the authors of the Jason Report met in a Greek restaurant. And on December 4th of that year, I announced from the podium that we had created the Argonaut Project. And the Argonaut Project was intended to drive the creation, the implementation forward. It's a private sector, independent of government support or financing, although input from government was as critical as ever. We followed many of the requirements and specifications of government. And I'm delighted to say that 3 years later, the 14 founding members of the Argonaut Project still meet every week. Different groups bring their ideas and their aspirations together and still partner in this really important endeavor. I had help and collaboration from other entities. The SMART initiative at Boston Children's Hospital created an infrastructure that provided the authentication and security upon which FHIR's utilization between health systems is accelerated and in some instances permitted. We have had a very close collaboration with a program on clinical decision support in which we leverage the capabilities of FHIR to provide something that I consider to be the sine qua non of an electronic health record. If you wanted simply a linear record of a patient, you could probably do it in Word or even a spreadsheet. But clinical decision support provides the key tools to driving quality. The HL7 Advisory Council strongly recommended that we carry collaboration another step further. And we created an initiative called Partners in Interoperability. And I recognize quite a few of you, and I know that you're active in this group as a means of accelerating how we implement the key tools to make interoperability possible. FHIR really is based on a limited set of resources. There's been a promise never to exceed 100. I think we bypassed that. But it lives by the rule of 80-20, that if you get 80% of the use cases rather than trying for perfection, you really solve many of the problems, and we can extend the capabilities of FHIR with ISO-based technology that we call extensions. FHIR has really caught on in the tech community, and they've done a lot to drive it in personal health, healthcare analytics, artificial intelligence, and a host of other uses that will make implementation of FHIR and accessibility of quality closer to a reality. We're partners with most of the key federal agencies that are responsible for or deliver health care, and a growing participation from biotech. The pharmaceutical industry realizes that the traditional double-blind, placebo-controlled trial is an anachronism. We get bad data, and we get drugs that work half the time. And if they're to achieve their goals, we'll need to get granular patient-level data, which FHIR can provide them. In the area of genetics, there are a host of projects ongoing. I think one of the most exciting one is Sync for Genes, in which FHIR methodology has enabled the incorporation of genomic material into the clinical record so that physicians at the bedside, researchers in the lab, and scientists in public health community can access not only genetic information, but the genomic and proteomic that will determine a lot about how we prescribe and take care of patients. It's an initiative to incorporate device information directly into the medical record, leveraging FHIR, as well as some contributions from a host of clinical professional societies at HL7 meetings and elsewhere, including the next partners meeting. Clinicians will bring their use cases, their needs, and their specific requirements to the table so that FHIR can meet their needs. Many other collaborations are really key to the success, including Sequoia and Care Quality, which now have driven some initiatives around patient matching utilizing the FHIR platform. We have a partnership with the CDC. Whether you realize it or not, there are 3,000 public health agencies in the United States. Half of them report to the CDC voluntarily by faxing Excel spreadsheets. It's no wonder that Google can predict an influenza outbreak before the CDC can by being able to extract clinical data directly from the record without parsing or participation from the provider community, it's really much easier for the CDC to do its job. There are a host of educational programs. One of the most exciting and most fun are the Fire Developer Days. Later this month, there'll be one in Amsterdam. The organization with headquarters in Amsterdam were the creators of this program, and we'll reprise it in Boston next summer. The most fun couple days in my calendar is the Fire App Roundtable. It's where developers have 15 minutes to showcase their Fire apps. Some of them have been remarkable, and others have been jaw-dropping. And given the ease of use and the rapid development time, it's spectacular to see what can be done in relation to patient care, the development of analytics, and even the application of personal health data to the decision process. So if you have an opportunity, I'll see you at LSU in New Orleans in December. I think one of the exciting parts about FHIR, and it's been unique in my experience, is the ubiquity of the participation and the outreach that so many people have to make this possible. So that's by way of saying, please join in. Your contributions are more than welcome. They're really critical if we're going to move forward. Lastly, tomorrow, we're going to have our inaugural Davinci Project meeting. Davinci is designed to enable payers, value-based care developers, people who believe that we can't continue to pay for services, we need to pay for quality, to participate in an event to begin a discussion about how we can use that clinical data rather than claims data for critical analytics and for making the cost of healthcare as well as the delivery of quality achievable. I couldn't help but ending the discussion with this slide. Like all other HL7 specs, FHIR is freely available. It's licensed under Creative Commons, can be implemented, used royalty-free in any product or services. So with that, thank you very much. Have a great 2 days. I look forward to chatting with many of you, and welcome to the Digital Quality Summit. Thanks.